Ladies and gentlemen, thank you so much for joining us on the Resource Optimization Network and Solving Healthcare webinar series. We're already at number 4, and we got a joint venture with Dr. Dave Neilipovitz, who's our head of our department, who you all, I'm sure, know, and also Scott Millington, who's one of our intensivists and ultrasonographer of the year. He got the ultrasonographer of the year award, and also in all honesty, extremely well published in terms of the world of ultrasound. So it truly is a privilege, and he's been working a lot behind the scenes in terms of how do we treat COVID. You know, these patients coming into ICU, it's obviously a novel syndrome, and the information and the appearance of these patients are always developing. And so I think it was important to talk about how we manage them. And so without further ado, I'm going to pass it off to my boy, Dave Neilipovitz.
Thanks, Kwadwo. And welcome, Scott. You know, and certainly to reiterate what Quad just alluded to, Scott's done a lot of the background. And so that's why I'm kind of honored to have him give me a hand as we try to go through treatment approaches for COVID-19. And with a novel disease, trying to have treatment options for something, for the most part, no one's ever seen before is obviously challenging across the world. And for the most part, we'll present what is been published, what's been out there. There's a lot of anecdotes, which is never great medicine, but it's kind of the best available information that we have. And the final aspect that we'll do is we'll try to mix in some of the Ottawa and surrounding area experience that we've had with it. And as some of you heard not long ago, Scott's just come off yet another week in the ICU. So I look forward to hearing some of his comments and his perspective on the management of COVID-19. Scott, welcome. Any words of wisdom before we get underway?
Thanks, Dave. Nope, no words of wisdom. Looking forward to it as well.
And of course, there we go. So there's been a frantic surge. I think everyone's quite familiar with all the different news reports of hopes and dreams for various treatment options. And obviously the impact of that would certainly be on patient outcomes, trying to help patients who unfortunately get this disease get better, and other ways to try to prevent it. There's a real big push, and you might have seen it come out last week that there was a big disappointment in several of the studies that were published. And you'll see even business journals and articles focusing on it, because the impact economically, both of the social distancing as well as the downturn in economies of the world, has been profound. And with that, there's a great impetus to try to find solution or solutions to try to make things better. When we looked for guidance on what to do, as is typical for any type of medical problem, is we try to get the best available evidence. What a lot of this is based on is these 3 sources for those interested. And basically, there was published by the Society of Critical Care Medicine of the United States, along with the European Society, some guidelines. For the most part, these were the surviving sepsis guidelines with a little bit of an update for COVID. So the applicability of these are a little bit limited. Last week, the Canadian group put out some recommendations as well. For them, there's 23 recommendations, with 1 being subdivided. For the most part, the only strong recommendations was for 3 different areas, along with 3 best practice recommendations. So roughly about 17 very weak recommendations, and weak being because the evidence simply isn't there. So that'll make it challenging for whatever we try to do and recommend, and recognize that what we recommend on May 4th, 2020 may not be the same even May 11th. And so we always recommend that everyone consult the best available guidelines at the time. The one that I personally liked the best, and not because the recommendations were always what I agreed with, but more importantly, it provided the most comprehensive recommendations along with multiple references to help guide the basis of how they generated that. And that was from the CDC. That's the bottom one of the three. And I would encourage you to kind of go there. It's kept up to date very, very effectively, and you can search your different questions and get the best available evidence. Scott, where did you find your information?
Yeah, I would give a second plug for the CDC website. It's got a lot of good stuff for treatment, and also just things like organizational aspects, which I found really useful. And I certainly agree. It's hard to know what to make of a recommendation that says, this drug may be used, or this drug should only be used within the context of a clinical trial. It's not the most directive and helpful advice, but a function of not having very much evidence yet. And just as we're getting going, I think it goes without saying, as you're alluding to, that it's going to get annoying if after every sentence I say, I don't really know, or I'm not really sure, or this is based on what I think right now. So we'll just maybe throw out the blanket caveat going forward, as you said, that this is based on a very rapidly evolving situation. And so it's very hard to be sure about anything right now.
Totally concur. There's even less evidence on this as compared to the PPE, which is a sensitive topic at the best of time. When we look at outcomes, and I think a lot of us were horrified by the numbers that came out of Italy, out of New York State. When you look at it in a deeper dive for the Italian experience, and these numbers are a little bit dated already, where they talked about an ICU mortality of 26% and a discharge of 16%, with the remaining being still in the ICU. So it's hard to say exactly what an ICU mortality is. It's always dependent on what your denominator is. If I was to give you some idea on the local experience, and this is our region, it's not just our hospital, our ICU mortality has been roughly about 20%. Our discharges, and what I mean by discharges, these are patients who survived their ICU stay and are discharged at least to the floor. Some have gone directly home. It's been encouraging in that it's about 60%, with still about a fifth of them remaining in the ICU at present time. So I think our mortality numbers are going to be similar to the experience out of Italy. Now, people will talk about the 10% mortality that Italy is reporting. Again, it's dependent on your denominator, and that was an overall mortality. We're focusing primarily on critical care. A study that came out of the UK was suggesting a 50% mortality. I think we'll certainly be below that. And so our experience has been better, but obviously 1 in 5 is still a very high mortality. Scott, have you heard other anecdotes about mortality?
Yeah, it's a tough situation to report on. It would, of course, heavily depend as well on what kind of patients you bring to the ICU. Are we counting quote unquote step-down units as ICUs? Are you in a very resource-rich environment where every case that you're at all worried about, you could bring them to the ICU just in case? That would obviously affect things quite a bit too. Or are you stuck in a situation where you can only bring intubated patients to your ICU? Those are some of the factors. And these papers getting pushed out quickly means that a lot of the patients are still intubated awaiting a disposition. Famously, that paper in JAMA that reported as high as an 88% mortality, which counted all the people who were still, or just had 3/4 of the patients still intubated waiting their disposition. So pretty tough to know. Otherwise, I'm encouraged by the numbers that you've shown there, I suppose.
And I just reinforce, like, it's important. This is a really important slide because that, JAMA, was it JAMA? Sorry, the New York data was potentially influential, You know what I mean? Like people might decide on management based on numbers like that. So I appreciate you guys just really illustrating what our experience is, just to put a realistic / local twist to outcomes.
Thanks, Scott. And just put it one further context that perhaps the audience may not be as familiar with. For a typical level 3 ICU, which is where we practice with ventilators and breathing machines and various things, a typical mortality rate in that type of environment is around 20%, depending on the type of patients you have. So the 20% mortality is not great, but not as discouraging as hearing about an 88% mortality and something to that effect. In terms of COVID-19 itself, how it presents, and this is what's made it kind of challenging for many physicians, in that the way it presents in patients isn't always the same. There's some patients who I think we're pretty familiar with now that are pretty asymptomatic in the community with it. But for those that end up coming that sick to the hospital, what was reported by Gattinoni and his group out of Italy is certainly, a lot of individuals are laying credence to it, is the two phenotypes, or so-called phenotypes. The phenotype H, which is patients who have a high elastance or very stiff lungs. These are the patients that really need intubation and ventilators. They are the traditional acute respiratory distress syndrome, ARDS, that we hear about and manage from other causes other than COVID. So that is pretty typical of the more severe form. What was interesting and unusual is the so-called phenotype L. The L stands for the lows. Low elastance are essentially normal lung compliance. And these are the patients that perhaps don't need intubation and ventilators, and we'll build on that shortly, but they're easier to ventilate. They need low PEEP, and these are not your traditional ARDS type of patients. Now, some of them can subsequently transform into ARDS, or so-called phenotype H, but managing these patients requires different approaches than if it was ARDS. And although this isn't universally accepted by everyone, I think our local experience would give credence to this. Scott, what do you think?
Yeah, I don't want to have too much of a hot take here, but I do have some concerns about this dichotomous classification. I obviously agree with all of the principles that you just mentioned, and I certainly acknowledge that this is an excellent starting spot. And I also acknowledge that Dr. Gattinoni has forgotten more about critical care medicine than I'll ever know. But I do have concerns. So, I think that this kind of implies that it's a dichotomous situation, whereas probably it's a spectrum, right? And, that's intuitive enough. You say on the slide here that it's type L is not ARDS, and I agree with it. However, it will meet the definition, the Berlin definition of ARDS, certainly for patients that are sick enough that you're considering intubating them. So again, that speaks more to the weakness, I think, of the Berlin definition of ARDS. But, technically by that definition, they are ARDS. Although, your point's well taken. And the final thing is that I'm a little worried that by creating this new type L phenotype, it leads to new ventilation strategies being developed, which we're going to talk about down the road. And some of those new ventilation strategies I have some concerns with, and we'll touch on that on later slides.
No, excellent points. I agree with your spectrum comment. And I think perhaps the most important thing to take home for health professionals managing these patients is to tailor the treatment to the individual's needs, as opposed to a blanket algorithm for all patients. And I think that's the important thing to take home, that there is not a one-size-fits-all management strategy for these patients. And this kind of builds on it. Like initially when we were hearing about COVID-19, the comment or the suggestion, recommendation was you got to intubate these patients early. You have to do so, because that's the only way you're going to save them. And I think what became pretty clear relatively early on, that this wasn't the perfect solution. So this one-size-fits-all approach actually probably potentially harmed patients. And so what a shift has been is to be more selective on who gets intubation and thereby a ventilator, in that, do they need it? Will they benefit from it? And that's the emphasis that we've tried to stress here, in that patients can be safely managed off of a ventilator. Now, Scott, you did a lot of work on the oxygen screen, and obviously if individuals really want to read this in great detail, they can go look at the website, covidottawa.com. But the premise of this test was basically to determine how well an individual responded to some kind of oxygen screening test, and whether or not they could potentially be safely managed without being intubated and on a ventilator, at least even temporarily. The idea is that you do the test for an hour and see how well the individual does, and that those who are not doing well, then we either escalate therapy if that's appropriate, or consider what is the most appropriate management for them. The goal of this was to kind of slow down the rushed intubation, as well as to determine what is best for an individual. Scott, you did a lot of work on this. What were your take-home messages for this?
Well, I think that, as you said, the initial word on the street just before we started to see patients was intubate everybody once they get to a certain arbitrary oxygen threshold. And luckily, again, just as the wave was starting to come, we got the message that that was not a great idea. It's not good for the patient. It's not good for the system to intubate patients who don't need it. And so exactly as you said, the main purpose of this is just to build in a little bit of a pause and to help disseminate that through a large institution like ours. And so you put the patient on this screening test, which we'll go over in a second, and that gives you time to do, I think, 3 important things. So number 1 is to see which way they're going to break. Are they moderately sick or are they severely sick? The second thing you can do is you can phone a friend. You may be doing some things that you're not perfectly comfortable with. This might be the first COVID patient you've seen, and so it's very helpful to get a friendly second opinion. And the third thing you can do is you can start to think about and explore goals of care, learn a bit more about the patient, decide if you think offering things like intubation and mechanical ventilation is right for them. You can have a conversation with the patient or their substitute decision maker and decide if invasive things are within their values and wishes. So that pause of approximately an hour allows you to do hopefully all those 3 things. The screening test there in the yellow box on the left, you can see you've got 3 options, the most straightforward of which is to put them on a non-rebreather mask, which again, you have to defer to your local institutional policies with respect to PPE. But at our institution, a non-rebreather mask with a filter can be put on anywhere. And so it's convenient. People know how to use a non-rebreather mask. And so this is perhaps the quickest way to get a patient out of danger, hopefully. Otherwise, slightly more complicated, you can use high flow nasal cannula or non-invasive ventilation. And you're basically trying to decide if they're going to pass or fail. The criteria are listed there below. I would just, to start with, de-emphasize number 2, just with your eyeballs, if the patient looks bad, then they fail. If they have work of breathing, accessory muscle use, and things like that, that is a failure. If you do a gas and they've got a rising PCO2 in the face of a high respiratory rate, that's a ventilatory defect, and that would constitute failure. So those things are fairly quickly done. And then the last criteria is the oxygenation, which is a little trickier in the world where permissive permissive lower sats, vocabulary, is perhaps acceptable. And so we'll talk a little bit about saturation thresholds a little bit later, but that one's a little harder. But those are some criteria for failure. Obviously, if their saturation remains at a low level despite high amounts of oxygen, then that's going to constitute a fail, and that means an ICU consultation. and further discussions perhaps about goals of care. If they pass, then they need to come into hospital, and the goal and the next branch point is, do they come under more of a medicine type environment, or are they needing ICU environments if they're still on high amounts of oxygen, even if they've stabilized a bit? And that's really the gist of it, I think. Communication between services is key, and so we've seen ICU medicine, the eMERGE team, other teams be involved, and communication being very important.
Thanks, Scott.
Help me out. What's the word I was looking for there?
Hypoxemia.
Thank you.
Permissive hypoxemia.
Thank you. That's
I was going to point it out, but I'm there to rescue you. So this, for those who don't know, that's a picture of a high flow nasal cannula, much maligned device that is purported to be aerosol generating, but that's it for another discussion. This certainly has, in our opinion, or my opinion, I won't project, a huge role for the management of patients who aren't being intubated. This is the so-called L type, or the pneumonia/pneumonitis type. Scott, you agree with this for this?
Sorry, the slide in general?
Well, yeah, you talked about, this is your slide.
Yeah. So, I mean, I just put some principles here. I think it's kind of interesting that you can derive, for better or for worse, some general principles from the way these patients present. Again, we're talking about the unusual L type with relatively normal lung compliance. So I've just listed some principles, and we'll come back to these in a later slide about ventilated patients. So, you know, they're not dyspneic. Certainly a large proportion of them are not dyspneic. And so from that you can infer, and once they get intubated, you can see that they have relatively normal lung compliance. They're very hypoxemic, and there's a debate. I put down shunt physiology there. There's a big debate as to why they're so hypoxemic. Some people think it's got to do with loss of hypoxic vasoconstriction. Some people think it's got a lot to do with severe atelectasis. There's a theory about micro thrombus in the pulmonary circulation. There's surfactant theories floating around out there. I don't think we have much clarity on that particular point. Number 3, you can infer that they've got relatively low dead space because their PCO2s are generally slightly low. Certainly they're not high in general. And then generally these people, depending on what phase of the illness is, you know, they're not having their best day, but they are generally normal in terms of level of consciousness. And they're strong, certainly strong enough to do the work of breathing on their own, at least initially. And so, again, theoretically, they're decent candidates for things like high flow nasal cannula and non-invasive ventilation.
Yeah, absolutely. And I think this slide just builds on that aspect, whereby what is going on potentially in these patients. The goal here, and people talk about silly. I'm not sure I'm solely on board with this self-induced lung injury component, but there is a lot about this disorder that's not very clear. The idea, however, is if you are going down this path, that you still need to watch these patients closely. We talk about looking for increased work of breathing, the permissive hypoxemia. What is an acceptable threshold? I think that's debated. I know Scott was advocating 80. Others were less comfortable with that. I'm somewhat on board with you, Scott, especially how quickly it develops. I mean, there's evidence that people will tolerate very low SATs if that develops over a period of time. So again, I don't think we have the perfect answer, but striving for 95 to 100% certainly is not recommended. The idea of self-proning has strongly been advocated, where patients basically turn themselves over onto their belly. It does help with their gas exchange in many patients. And the role of sedation, I was certainly struck by the high needs that a lot of the COVID patients have. They're very resistant as compared to other individuals. Scott, do you have thoughts?
Well, I mean, just to touch on the oxygenation question again, it's really hard. It sounds easy just to put a algorithm on paper, but these patients are dynamic. They're moving targets. They're getting worse. They're stabilizing. They're getting better, and minute by minute, their saturations are changing. They might take a sip of water and desaturate down to 78. And so, is that a failure? Even if you're using a low threshold like 80, I don't know. If they pop right back up and they look good, that's okay, or maybe it's not. I mean, these things are really hard, and it's especially hard. I would just throw out to say it's especially hard for the nurses and the respiratory therapists who spend so much time at the patient bedside. And so for us to wander by and see the patient looking pretty good at that moment in time and be reassured is one thing. But if you're the ICU nurse or respiratory therapist or physiotherapist who has to spend hours at a time, it can be a lot harder to stare at a number that you're generally programmed to be uncomfortable with.
Yeah, I totally agree. I mean, the favor is when someone's telling you a story and they're desaturating at the same time, but they're not distressed by it, but you're distressed by the numbers, how they're going down. It raises questions. Am I doing the right thing for my patient by not putting them on a breathing machine in the traditional sense? With that raises the question of when do you intubate? And we went from one extreme of intubate everyone early, and then I worry that sometimes there's too much of a shift the opposite way of not intubating enough or soon enough. Some of the things I look for is certainly the aspect, do they look unwell? Are they troubled? Do they have worsening work of breathing? In terms of severe hypoxemia, you can see that we didn't put a number there. Again, what is acceptable, what isn't, certainly is subjective. And finally, just simply failing to tolerate what you're doing. But again, I don't have an easy threshold or to say at this stage you have to intubate. Scott, do you have any magic answers for people?
And I guess I'd add PCO2, if they do have a ventilatory defect, and I think that that's a red flag that is actionable here. But otherwise, I would just echo your comments about this being extremely difficult. And it's difficult because, you're doing a complex probability calculation and you're not allowed to know any of the actual numbers. So, if a patient can sail through without needing intubation, that is a massive advantage. And the patients who seem to do best are the ones that avoid intubation. So how much are you willing to risk to try and offer the patient that resistance, that low resistance pathway to doing well? You also have to factor in that intubations in these patients can be dangerous. Of course, dangerous to staff, but we'll leave that for the moment and just talk about danger to the patient themselves. The numbers are something like 6 or as high as 10% of these patients have a cardiac arrest on intubation. And so, we could hope to do better than that, but nonetheless, there will be a risk of that happening when you intubate them. So just to point out that there's a lot of moving parts here and the decision-making is challenging.
Absolutely. And just so everyone's clear, that there's also an association that those who are doing better may not require intubation and thereby do better. So take the numbers always in context of what it is. But I agree, if you can avoid it, I share your bias on that, Scott. Now, everyone likes algorithms and to simplify, so why would we not have one as well? But obviously it's hard to read, and you can see the reference where to go for it. Again, this is for starting, and I think that's what everyone should be taking home, that there is no perfect way to ventilate these patients. But with the idea of the two phenotypes, the traditional ARDS, you see some of the initial vent settings that we recommend. And that's out there for a start, and then titrate and adjust based on patient needs. And I think that's the most important. We're pretty aggressive at proning patients with the H-type or the more severe ARDS-like problem with COVID. Use of paralytic agents certainly is advocated. It's the L-type that Scott has already talked about and alluded to that is kind of challenging. There are some patients who clearly don't tolerate the high flow nasal cannula or other related types of oxygenation devices. Some do require intubation. Whether they're about to transition into more of a typical ARDS pattern is always hard to predict. You can see our initial settings there. For the most part, slightly higher tidal volumes than traditional ARDS management. Probably the most important thing is the other yellow arrow is pointing to a lower PEEP. So you don't need the high PEEP in these patients to improve oxygenation. What do we follow on a regular basis, particularly for the pneumonia type or the L type, is to measure the compliance daily as well as the driving pressure. As the compliance is typically over 40, which is suggestive of normal lungs, what you would see is if they're transitioning into more of an ARDS-like pattern, that you'll see the compliance get worse. And likewise, the driving pressure for the L type is normally under 12. That's plateau pressure minus PEEP. The lungs are essentially normal as opposed to the higher pressures that are required for the ARDS patients. Scott, do you have anything to add on this, or just to emphasize these are the two extremes of the spectrum and to adjust your management according to the patient needs?
Yeah, I have some thoughts, but I could save it for the next slide. So this is, these same sort of principles I've listed on the previous slide down the left hand, and the study I reference here, I don't think we want to get into looking at studies in detail, but it just kind of made a point that I'm worried about. So this is a study that you can look up. It was published 3 or 4 days ago out of Boston, and it's 66 ICU patients, all intubated, and they all have a disposition. So these patients have all either survived or passed away. And so from that, you can tell that this was a study that was done very early on when the wave was first crashing in the United States. And so they didn't have as many of these concepts fleshed out in terms of L-type or H-type. And when you look at the study, these were mostly L-type patients. So they mostly had pretty normal compliance. And so what did they do with these people? Well, they ventilated them like we always ventilate ARDS patients. They ventilated them with a low tidal volume strategy and with not high levels of PEEP, but normal levels of PEEP for an ARDS patient. So they used the standard ARDS approach for these patients, and their outcomes were good. The mortality in this cohort, again, all intubated ICU patients, was 16%, 1/6. And so that's, the source of my concern that maybe, and this is obviously just a hypothesis, but we shouldn't do things too different from normal for these patients once they get intubated. I certainly agree with all your concepts about, the PEEP, if anything, doesn't need to be as high as usual. The tidal volumes might want to be a little bit higher than usual, but I have some concerns, some worries about the recommendations that have suggested going as high as 8 or even 9 milliliters per kilogram. That seems high to me, and I'm a little worried about jettisoning a very evidence-based component of ARDS care here. So time will tell. And then, if you can look down the slide, now we're talking about patients who have been intubated with the L-type. They have relatively normal compliance for an intubated patient, so you have to worry about overdistension. Barotrauma, volume trauma is, that risk is there theoretically. They still have the same physiology that's causing severe hypoxemia, and you still have the same problem with respect to your oxygenation targets. I would not advise aiming for saturations of 100%. You'll presumably get oxygen toxicity and excessive PEEP if you do that. They still have relatively low dead space, and so at least at first, until they stiffen up, they're relatively easy to ventilate, and by that I mean get rid of PCO2. And then the recruitability thing that you're touching on, if you give them too much PEEP, they're going to get hypotensive, and that's a big problem because they're going to end up getting fluids, and that's bad as far as we know. But then again, there is concern out there that if you use an ultra low PEEP strategy, then they may be victim of atelectasis, and then the cyclical closing and reopening of alveoli, or so-called atelectotrauma.
Great. I think the strategy of avoiding extremes yet again bears out in yet another illness, as it does in most illnesses. I find it interesting on those results that you're presenting. There's the roughly about 1 in 5 requiring tracheotomy, which, interesting, when we did ours, there was a lot of pushback on it. And you can see that avoidance of tracheostomy, which has been advocated by some groups, I'm not sure is the proper strategy. And certainly selective use of it is probably quite appropriate. When we admit to the ICU our COVID patients, for the most part, it's typical ICU admission orders. A lot of it is supportive measures. You can see that we do follow the CRP, the ferritin, and the D-dimer. And rightly or wrongly, and we'll get into it a little bit, we don't know if that's the right answer. Certainly, many of us are speculative on it, and we'll show how, at least for myself, how I use it. What we do believe is the idea of early feeds, but low intravenous fluids. And now, I know everyone's always worried that, oh, you're running your patients dry, they're going to require dialysis. And I know for a while, early on when we were hearing about COVID, there was a concern about high renal failure. For those interested, at our area, we've experienced roughly about a 20% need for dialysis for patients of new onset dialysis. A little bit higher for those who've had renal insufficiency, but in terms of dialysis, actually 10%, sorry, I think I said 20%, 10% was the rate of dialysis, new onset of dialysis, and 20% was roughly those who have renal insufficiency. So pretty significant, but not as high as some sites have advocated. So I think we're finding the reasonable balance from running them dry. In terms of specific and supportive measures, we'll get into in a little bit. Scott, anything else you like to do when you admit the patients?
No, I think you've covered it pretty well. Whether they have a co-infection is often very difficult to sort out, and most of these patients get put on empiric coverage for a community-acquired pneumonia, which you could certainly understand. Otherwise, I would second your restrictive fluid strategy. Absolutely.
Yeah. I think once we get quicker results on our COVID testing, the need to cover for differential diagnosis like community-acquired pneumonia. I know we also look for influenza. Initially, our response getting the COVID test results back was 48 hours, 72 hours, but they've become very good with that. So I think the need for antibiotics, at least initially, will become less and less. In terms of medical therapies, and I think this is what everyone's looking for, the panacea of solutions. Now, there's two important concepts that we'll dive into just briefly, and then we'll save some time for some questions. When you talk about the different treatment options for COVID, there's two components, and that's the mechanism of action of the purported treatment, as well as the timing. And both of those concepts are very important, because if you use it at the wrong time or the wrong drug, don't be surprised that you don't get the treatment that you desire. In terms of mechanism of action, there is two subcategories for the most part for this. It's either directed at the virus or directed at how the patient or the host responds to the infection. You can see in the illustration here that the virus attaches via the ACE2 receptors, and that's perhaps why some people are concerned about ACE inhibitors and things, which if there's questions about that, we can go into it. But the drug binds to the ACE2 receptors, enters the cells, and thereby undergoes replication. There's various medications that either impair the binding to these ACE2 receptors or the subsequent reproduction of the virus within the host cell. And that you can see that's where the chloroquine perhaps impacts, as well as the various other antiviral agents in that regards. In terms of the host response, a little bit on the illustration, it's basically what you're trying to do is impact the immune response, or actually target the virus in the bloodstream, as well as some of the complications such as the need for anticoagulation, which we'll build upon shortly. timing as well is crucial, and you'll see this slide again shortly. But what it's showing is that as the virus comes into the body, there's a so-called viral response phase, and eventually there's the host response or the inflammatory phase. So you can see various medications at the bottom that would only be effective at certain stages. It also is important because some medications may actually be harmful dependent on the time that they're actually administered. So that if you attempt to reduce the immune system too early, it may actually have detrimental effects. Some drugs have a larger therapeutic window, but don't be surprised that some medications all have limitations with that. Scott, anything about timing or mechanism that you want to build on?
Yeah, I mean, I think you did a great job outlining the issues here. I think that the challenge is going to be that most of the agents that interfere with viral replication, of course, the earlier you give them, the better. But because you're not seeing these patients until day 8 or 10, the mean day of presentation to certainly an ICU is something like 10 days. By that time, I think the horse is out of the barn, so to speak, and you'd expect those medications to be less effective and the side effect profile to be perhaps more concerning, although these seem to be pretty well tolerated drugs in general. And then I think, when this slide comes back in a couple slides, we'll use it to talk about timing of steroids again, and I find that to be a particularly interesting issue. But I'm hopeful, if I'm hopeful at all for some of the treatments that are on the table right now, I'm hopeful for them in an outpatient setting, where you're hitting viral replication before the patient gets very sick.
No, I agree. In terms of the antivirals, I think this is what a lot of the press is focused on, these medications. I think many are aware that hydroxychloroquine was advocated by the president. Unfortunately, the purported benefits were not only probably overhyped, there's evidence that you do have something to lose, because there was an association of sudden death, cardiac death, with the use of hydroxychloroquine and its parent drug of chloroquine. How those drugs work, again, you can see that they impact the virus being able to bind to the host, as well as impacts the immune response with that. What did come out of the recommendations was pretty clear to avoid the use of hydroxychloroquine with azithromycin, which is important for people to be aware of, because that combination was actually the initial recommendation that all of us had, was to give azithromycin along with hydroxychloroquine. The concern being they both affect the QT interval. Interesting enough, a sudden cardiac death wasn't even associated with typical QT responses. So whether or not hydroxychloroquine by itself has a role, perhaps is somewhat debatable, but for the most part, the evidence isn't supportive of it. In terms of the HIV protease inhibitors, the lopinavir combination with ritonavir, for the most part, it is affecting the protease that splits the virus within the cell. Unfortunately, most of the studies have not shown any significant benefit. The drug that, at least for me in my readings, made the most sense is the remdesivir. And the reason why for me it had the most sense was because the drug actually has some activity against other coronaviruses, most particular the MERS, which is the Middle East respiratory coronavirus that we heard about, I think it was 2 years ago. For presently, it's only available on compassionate release. Last week, you might have heard Dr. Fauci out of the United States talking about a press release from the company that suggested it reduced the duration of ventilation. The timing of that was curious, in that there was a study released in the Lancet of a Chinese study that basically reported no benefits with the drug, except perhaps a decrease in time until there was benefit in patients, but that's really not a real outcome for most of us. So unfortunately, these drugs for the most part have been very disappointing. For me, Scott, I don't know if you had any other thoughts on it.
Yeah, I would agree. I mean, remdesivir, we're going to hear a lot about it, I suspect. I would not predict it will be an ICU drug. I would predict that the best case scenario would be it would find a role in patients who are earlier in their illness and prevent some ICU admissions. I guess that's the hope here. But all the studies, even of remdesivir, to my eye, are still well within the range of only hypothesis generating.
Yeah, and getting access to the drug obviously requires compassionate release, but since it comes from the United States, I'm not sure we have ready access to it, unfortunately. Interesting for those, it was developed for Ebola along with influenza as well. The other treatment that's gotten a lot of press is kind of an old style type of treatment. That's where basically you're trying to transfuse antibodies from a patient who you believe is immune to the virus into a patient suffering from the virus. And although initially I thought this made a lot of sense, it's been used for other diseases and disorders. Part of the challenge is that we're not even 100% certain that those who've been exposed to COVID and have antibodies are actually immune to it. My suspicion is that they probably are, but again, that still needs to be clarified. What I found interesting, this is important if we ever talk about vaccines for COVID, is the so-called concept of antibody enhancement. And what that is, maybe everyone's not familiar with it, but basically, if you don't have a perfect match, that the patient's response when they get an infection may actually be worse than if they didn't get the treatment. The classic example of this is for dengue fever, which has different virus serotypes. So that the first time you get the dengue fever, your response isn't as bad as it is in the second infection with a different serotype. So you actually get an enhanced immune response that can actually be worse. And so that's the downside of a poorly matched vaccine and potentially with plasma. The other immune modifiers.
I'm sorry, Dave, I just sorry to cut you off, but just to reinforce that antibody enhancement, like with that dengue vaccine that you were citing, like there was mortality, like kids died from that. Like it was like a real issue. And so I just want to make sure it's not, people listening, it's not just like this theoretical, hey, let's not get too worried about that, but it was a fatal consequence.
Thanks, Scott. And absolutely, and that's I see that less of an issue with plasma potentially, unless there are now different serotypes of COVID, but it certainly is a real concern. Likewise, the other immune modifiers of the various interleukin types of drugs, the anakinra, which is an anti-interleukin-1, and the various MABs, again, they potentially may impact the host in an adverse fashion, particularly if used early on. Scott, anything to add on those, or we can move into the corticosteroids?
Yeah, we can move into steroids. My only comment here would be that I'm cautiously optimistic about plasma or serum therapy, but you would predict based on our hypothetical model that it would be more effective the earlier in the disease you give it. So again, it's probably not something that's going to save an ICU patient, but maybe would prevent an ICU admission if given very early in the course.
Yeah, I agree. I think it would speed up viral elimination, but if you have an adverse immune response to it, it perhaps may not be the answer. In terms of corticosteroids, what was initially recommended was complete avoidance of this, that it worsens outcome. And I'll let you discuss it, Scott, but I think you and I both agree that it at least has a role in some fashion. and perhaps I'll let you go first and say where you use it and how you would like to see it used, and I'll touch on that as well.
Yeah, my bias here, and I'm certainly very willing to be wrong about this, and worried that I will be proven wrong with time. But as currently stands, my bias is somewhat pro corticosteroids. You do have to kind of go through the thought process here. The studies about increasing the time of viral shedding, so potential harm, tend to be in studies where the steroid is given early, and so that's something that we shouldn't do. Looking at the graph here, once you're in the pulmonary phase, so 2A or 2B, that's where hypothetically a low dose steroid regimen, so typically in the 0.5 to 1 milligram per kilogram range of something like methylprednisone, would hopefully blunt the host immune response. And then the other place that it could be considered would be in a very sick hyperinflammatory phase to give higher dose steroids, which would have some overlap with perhaps ARDS care writ large. So it's complicated. The credit here on this slide, I've shown the actual study at the bottom. On the bottom right, I've referenced a blog called the PulmCrit, and Josh Farkas from Vermont. I would recommend this if you're looking for a place where really smart people discuss this issue in sort of narrative form, or even in debates. And so some of the ideas here come from there. So that's a really good resource, I think, that people could check out. Again, if you peel through all the studies with the eye of faith, you can convince yourself that there may be a role for steroids here, again, either in that middle phase or in that late phase. But again, we're looking at subgroup analysis of small studies, and so we're firmly in the range of hypothesis here, and that should be clearly understood.
No, I agree, and I'll touch on a little bit what I'm using. I think what we're both advocating is that if you feel the inflammatory response is excessive in some fashion, that's detrimental to the patient, that perhaps there is a role for corticosteroids. I think you were alluding to the mechanism here and what you're
I'm not a pathologist, so no follow-up questions, please. The beautiful pictures that you see here are something called AFOP, acute fibrinous and organizing pneumonia. So this study that I've cited here is a French study with 5 COVID-19 patients who died after late stage illness, and all 5 of them had this particular pathology on autopsy. You can go back to SARS data and a study out of Toronto with 20 patients, again, late illness deaths, and about a third of them had AFOP, a third of them had diffuse alveolar damage, which is the typical pathological finding associated with ARDS, and a third of them had a mix between the two. So AFOP exists with these viral infections, and the key term here, and basically my complete understanding of this, is the last 2 letters are OP, which is most closely associated with COP, or cryptogenic organizing pneumonia, which is a steroid responsive condition. So again, all I'm saying is that we've at least cleared the first hurdle here, which is biological plausibility.
Excellent. And Scott, we'll talk about the stain technique on these for those interested.
Oh yeah.
So what's a follow? And I think this is the big challenge. That's Scott showing how well he balances in his off hour time. And it's the avoidance of extremes. And that was a concept we introduced earlier. And the idea, when I was managing these patients in the unit, I certainly didn't want to go one way or the other too far. Certainly looking at a fluid balance, ideally 0 balance or slightly negative is what I was trending. But, I was giving fluid boluses targeted when I felt that perhaps we had overdone it or an individual wasn't taking in enough fluids. I do look at the inflammatory mediators. In terms of the CRP is what I would particularly look at, and then if my patient was getting worse and I saw a new spike in the CRP, first and foremost, rule out other causes for the inflammation, like infection, which certainly these patients are at high risk, but did start high dose corticosteroids in an individual who suddenly had a new increase in that with no other explanation, and worsening gas exchange and worsening clinical appearance. Was that the right thing to do? Perhaps time will tell us whether it was or not, but that's how I tend to use it. I always struggle with the ferritin. I always used to say that's a small furry animal that some people have as a pet. But again, I would associate that as another sign of inflammation. The final thing I'd look at was the D-dimers. And for what was typically a limited value test, what I would use it in my COVID patients was, again, if they were worsening and that in isolation was increasing, I was worrying about too much coagulation happening in the microvasculature, and that I would think about increasing the anticoagulation in my patients. And so normally we had them on twice a day DVT prophylaxis of a low molecular weight heparin, but that if I saw that rising, I would begin to push the envelope of anticoagulation and actually measure the anti-10A for that. Scott, what would you follow on your patients when you're caring?
Yeah, I agree with the approach. I mean, if you want to loosely tie CRP to steroids and D-dimer to dose of anticoagulation, that makes a ton of sense for me. Something that I've never thought about before, but now I'm suddenly fascinated with is the kinetics of these things. So how fast do they go up? How high do they stay up after insult? How quickly do they come down? These are things that I don't understand at all, and needs clarification certainly for me. But yes, I've been using steroids. I hope it's the right thing to do. A patient sick enough to come to the ICU, whether intubated or not, who has a high CRP, then I've been using a dose of about 40 of methylpred BID, which intravenously, which is based on a common regimen in New York. And so I suspect that we'll see some observational studies of that dose coming out in the next few weeks. But admittedly, that's not based on any particular evidence, solid or otherwise.
Yeah, I use slightly higher, roughly about 60 twice a day. And the idea, again, being for 48 hours and then rapidly tapering down. So again, this is anecdotes, and I trust everyone appreciates that we don't have the perfect answer. Again, I don't start all my patients on corticosteroids. It was only in those who were worsening that I saw other signs of inflammatory changes. The last aspect is going to be on clotting. Scott, I think we're aware that these patients at higher risk, there's some questions about alteration in plasmin, and the evidence is pretty clear that they do get a lot of microthrombi. The question is really why and what do you do with it? What was your approach on it?
Yeah, it's evolving over time as well. I think the default stance, unless there's some unusual and strong contraindication, would be to give at least aggressive DVT prophylaxis. The study that I show on the right there is a study from China. Unusual study. They had patients on nothing. They're not on full dose anticoagulation. They're not even on prophylactic doses. And they had a very high incidence of thromboembolic disease, as you might predict, something like 30%. And the interesting thing out of this study was the D-dimer cutoff. So you have to convert that to our units. So it'd be 1,500, not 1.5. So the patients who had a D-dimer above 1,500 were at very high risk of clotting. Now, this is off everything. So I was loosely using that as a cutoff. And again, in a patient who's very inflammatory, and certainly we've seen D-dimers quite a bit higher than that, I would have a strong bias right now towards fully anticoagulating them, provided that there's no contraindication to it. And I'm not sure that's the right thing to do. Certainly, they all need to have at least very aggressive prophylaxis, I would argue.
Yeah, and you were using low molecular weight heparins, I think, for the most part?
So a lot of the time I was using plain heparin at first, because you're not exactly sure which way the renal function is going to break. Once the patient had settled into a pattern where it looked like the renal function was going to be stable, I was often transitioning over to low molecular weight heparin. And there's a debate, I gather, about which, you're wondering whether there's some anti-inflammatory effect of these agents that might be offering a side benefit. whether enoxaparin or heparin has better anti-inflammatory characteristics. I don't quite know the answer to that question. I'd always assumed heparin did, but people are telling me I might be wrong about that.
Yeah, I don't have the answer. I was actually using enoxaparin, which I think you'll know that's not my typical approach. But I was more aggressive in actually using the low molecular as opposed to our traditional unfractionated heparin. So with that, you know, some quick questions I'll ask, and then we'll get into it, Quad. I'm sure you've gathered some. When do you extubate your patients? Scott, like, what was your criteria? The typical, or?
Yeah, I don't have any strong advice to offer here. We're dealing a little bit with low sample size problems here because, you know, we've been relatively spared as a center here in Ottawa. And because of the length of illness that these intubated patients typically have, the issues around extubation don't come up very often. I extubated, you know, 4 or 5 of them, and I used fairly standard criteria.
Yeah, I think one of the big take-home messages was potentially wait a day or 2 longer to ensure that they're not transitioning or going to get worse. There was also a lot of anecdotes about airway edema and whether or not the ACE2 receptors that are in the oral pharynx and things as such may be swollen more than your typical type of patient. So there was a question. I think anytime you extubate, it's always that you may have to re-intubate, and just the challenges that this population in terms of protecting the staff in terms of re-intubation is certainly a factor. In terms of medical therapies, for the most part, you know, maybe I'm wrong, but I wasn't advocating the use of hydroxychloroquine in my patients because I don't think the evidence was there, and my concerns was the cardiac. So I actually recommended not starting it in an individual. And who knows if that was the right question. Certainly stand by not including it with azithromycin.
Yeah, my only comment here would be that enroll these patients in studies wherever possible. That removes your barrier to procuring the drug, and we'll hopefully learn something.
True. I guess my issue was I wouldn't put them on it regardless, and so it's always hard to put them in a study if you believe it's potentially harmful.
Yeah, fair enough. Fair enough.
My ethical dilemma. In terms of a tracheotomy, obviously I'm biased, and I do feel there's a role. You're okay with it?
Yeah, I tend to agree. The safety of the staff is the concern here, and so you have to be at an expert center. You've obviously been involved in more of these than I have, Dave, but I think I'd guess you'd agree that communication between the anesthesia and surgical team in terms of timing of having the airway open and not open is going to be the most important thing here. So you got to be a well-oiled machine.
Yeah, and I actually, you know, in spite of some of the recommendations, I think a perc trach is way safer than an open trach. I hope people understand the open trach recommendation comes from SARS when we weren't actually even doing perc trachs, so limited on that. And before we go take questions from the viewers, what was the most important thing you think you learned about managing COVID patients?
Boy, wow. I mean, certainly feeling humble these days and aware of the limited knowledge. We've never had, at least in my career so far, a brand new disease. Not only a brand new disease dropped into your lap, but a brand new disease that fills up half your ICU. It's quite amazing. And the pace of change here has been remarkable. And so anytime you think you're sure of something, you better think twice.
Yeah, no, I think the thing I learned the most is what you don't know. And so when people say, well, I know how to do X or Y, I'm like, well, that's good because I'm not sure I have the full confidence. So maybe Quad can tell us what he learned and what questions, you know, Scott can answer because he's He's more of a geek and a smarter guy than
Well, first of all, thank you guys for doing this. I do want to echo one of the things in terms of what we learned. I can't think of, yes, it's a new disease. It's a new, it fills up your ICU, but a lot of the stuff we were seeing wasn't intuitive. You know what I mean? Like this hypercoagulability, like above and beyond other viruses or illnesses that we've seen. This talk of COVID brain, the different types of presentation in terms of the lung pathology, like compliant versus non-compliant lung. Like it's different. So I'll echo what Scott was saying, is like how humbling this could all be, and what is how agile you need to be, you know what I mean, to be able to really take this illness seriously.
You need to be agile so you can jump from one wrong answer to the next wrong answer.
Exactly. So there's quite a few questions here. I'm going to start with one of my own, actually. Anticoagulation. Since we started to take it more seriously, have you noticed any difference clinically of the prevalence of dialysis needs?
No. Again, small sample size being the problem here. I think the autopsy studies that I've seen, and somebody will correct me if I'm wrong, I hope, is that renal vascular microthrombosis does not seem to be a prominent feature, which is curious. So I would not guess, and it's a pure guess, that anticoagulation would do a lot for your renal failure. And I haven't had a high enough sample size to really know. And I think my experience is also confounded by the fact that I fully anticoagulated nearly everybody. My relatively small subset of patients, I did not have a lot of renal failure, alluding back to a point that Dave made right off the top.
Yeah, I think I have to echo what Scott's saying. Is I was aggressive with the anticoagulation, and the person I took over from was also aggressive with the anticoagulation, so we didn't see any renal insufficiency. So cause and effect or association is hard to say.
Fair enough. Okay, this is an earlier question in terms of the differing phenotypes. Are you noticing a different presentation amongst them? Like, so, is the compliant group, are they more diabetic or hypertensive, for example? Have you noticed any similarities in that fashion?
I haven't noticed myself. I think that the answer to that good question is going to hopefully come out of New York data. A lot of this is going to depend on, socioeconomic determinants of health, I think. And if you're in a system where people are presenting later in their illnesses, you're going to presumably see more type H's. And if you're in a system where people come to the hospital in general quicker, you're going to see less. And I think we're more of that latter category. So people are coming before they're at death's door. So yeah, I have not particularly noticed an association. My big concern is that it's the iatrogenic shift from L to H that can happen. And so this is ventilator associated, whether that's barotrauma, whether that's atelectotrauma, whether that's just virtue of getting these patients intubated, sedated, they get a bit hypotensive, they get fluid resuscitated. All these things mixed in a bag, I worry, can increase the stiffness. And so by avoiding that wherever possible, I hope to avoid that progression.
Yeah, I think I would concur with most of what Scott said. I think the volume hasn't been clear enough that we'd be able to do that as a single center or at the two campuses. So I think you would need a larger demographic database to be able to answer that.
Absolutely. Okay. The cardiogenic shock. So we used to hear a lot about that in February, early on, about some of the cardiac sequelae late sequelae of COVID-19. Are you seeing any of that, or are you doing any kind of surveillance to manage that?
Well, you know me, I am echoing all my patients systematically, of course, as is my habit before COVID and certainly during COVID. I haven't seen any of it, like zero. Again, small sample size theater here, so I take that with a huge grain of salt. But I haven't seen any, and I haven't even seen left ventricular dysfunction on echo. These patients are typically have normal LV systolic function, or they're more of a septic type picture, inflammatory, hyperdynamic, et cetera, et cetera. So I have not seen it, but I know it's well described.
Well, it's certainly well described out of the Seattle group, where they talked about this cardiomyopathy, I think about 33%. I agree with you, Scott. I haven't seen it, or I'm not smart enough to recognize it, I guess. There is a cardiac surveillance program going on at the two Ottawa hospitals in conjunction with their cardiology colleagues, but we certainly haven't seen it, which it'll be curious to see what comes out of New York and some of the other centers, and perhaps we can eventually do a deeper dive of why Seattle reported such a high value. Like, I wonder if that's also, were they more aggressive with the azithromycin and hydroxychloroquine? And so I think that's maybe where you're going. Is that a treatment-related effect as opposed to COVID per se?
Yeah, because it is odd that, like, why should it be more prevalent there? And personally, myself, just to echo what you guys said, I'm not seeing it at all in the low sample size patients that I've seen. There was a question by Jasmine earlier about ECMO, whether it's a reasonable or fair treatment modality in the context of COVID-19. She asked specifically for the H type, but I think whether H or L, any thoughts on ECMO as a treatment?
Dave, you want to take first crack at this one?
So ECMO certainly probably has a role for salvage therapy, for want of a better word. I hate how they use that term, but that is the term they use. It is predominantly for the severe ARDS type of patients. They had toyed with it about the cardiac for the cardiomyopathy, but as we kind of alluded to, we're not seeing that. I do know in the province that I don't think we're up to 20 individuals, but somewhere in that, with a reasonable survival rate that I'm sure the province will report soon. What was initially being purported was that the results were very poor and dismal. And I think what's panned out is that is not the case. For those listening who may not be aware, that the survival rate for ECMO for other disorders may not be as great as what it is for the non-ECMO patients, but they are getting favorable outcomes, with some patients have gone home. And so I think it does have a role, certainly perhaps is limited and who could benefit from it. But short answer is yes, it does have a role.
Yeah, I certainly would agree with all that. It doesn't come up as often as you think it would seem, and that's because there are these established relative and absolute contraindications to ECMO, which you could certainly argue about each one and potentially reassess them in the face of COVID. But most of your patients who do poorly are going to meet one or more of those at least relative contraindications, at least, if not the absolute. So the patients that are at higher risk of doing poorly are patients who are older, patients who have significant medical comorbidities, et cetera, and that will rule them out of ECMO by traditional criteria. And so it's not an issue that's coming up as often as you might suspect.
Excellent, thank you guys. I think those are all the major questions that I see there. I want to really, once again, thank you for the time for discussing these treatment options. There's a lot of as we've mentioned before, a lot of fluidity to this, and there's a lot of, anecdotal evidence and so on. But it's good to hear what some of our colleagues, how we're approaching these problems. Like even the other day, I got a text message asking about D-dimer cutoffs for anticoagulation. I'm like, you know what? I don't know. I really don't know. Like there's so much in the air, but to have that kind of dialogue to really get a sense of what the mindset of our colleagues are, and we really want to just serve and do our patients as good as we can. So I think this helps, and I really appreciate what you guys taking the time.
Kwadwo, are you going to be able to edit out that part where I forgot hypoxemia? That was embarrassing.
I do a blooper clip at the end. I just put it on repeat, buddy. I just keep it going.
I swear I'm a doctor.
Yeah. Short of hypoxemia, I think the most important thing that everyone should take home is that we're learning from each other. Certainly, I know Akshai's on the webinar here, and we talked with him, who's one of our colleagues at one of our sister hospitals who got the initial wave. And again, there's no perfect answer, there's no perfect way, and what we're trying to do is adjust our treatment to how the individual is responding. Although we presented like a dichotomy for some of the presentations, I think Scott's word of spectrum is very correct, and I don't think there's a one size fits all, and don't be afraid to ask for help. Like I came there to rescue him about hypoxemia, and I'm sure someday Scott will find something that he'll rescue me on. So it's all good, and the nurses have adapted perfectly to this. The RTs, respiratory therapists, along with our other health professionals like pharmacists and dietitians, and our physical therapists.
Yeah, it really is in some ways almost special to be a part of it, because it's really like a lot of people in a collaborative effort with the same goal. Like you feel like you're part of something special. All right, gentlemen, thank you for doing this. Those that are on the other side, thank you for the questions. This is going to be posted up on YouTube in a day or two, and also I will put it on as a podcast as well. So there'll be an audio reference. But thank you so much, and everyone stay safe.
Thanks, Quad.